So, I'm Bryant Oliphant. I'm an orthopedic surgeon by training. I do specialize in orthopedic trauma. I'm associate professor down at Wayne State University, and I practice clinically at Detroit Receiving Hospital. I'm also do health services research in the Department of Orthopedic Surgery at the University of Michigan. I'm just finishing up a K award in the next few months through NIH, and I'll talk about the R1 that we um, have submitted and kind of got evaluated recently. So we'll talk about that. But this is kind of the intersection of a lot of the stuff that I do. And so today I called it MTQIP 2.0, and I'll explain what this means, how to use new data and technology to improve outcomes in trauma patients. So here are my disclosures. As I said, I'm on a K Award. It's going to end soon. I'm also a specialty consultant for the Michigan Trauma Quality Improvement Program. I'll go into more detail about that, but basically one of the Blue Cross sponsored CQIs housed at the University of Michigan. This is unique to trauma. And also the consent obtained for patient case examples, you'll see shortly. So, like I said, for more disclosures, I am an orthopedic traumatologist by day. I spend a lot of my time fixing broken people. So, if you get in a car accident, jump out of a window, get shot, whatnot, have a fall, as my father-in-law says, you don't want to see me, which is true when people come up at family reunions and want to have the conversation about their knee hurting. It's like I'm not the person. I'm also a budding health services researcher. I did mostly clinical work until some years ago, and then had a little change of career change and path, and became a health services researcher, and still growing in that and learning. And I'm also kind of realized that research is a team sport, and we'll see a lot. There's a lot of different roles, a lot of different expertise, and I think harnessing that is probably one of the best things you can do, at least as in research, to make it happen. And so, kind of something to think about as we go through this is trauma is not an elective event. So it's unlike other stuff where it's kind of planned. No one plans on getting in a car accident, when they wake up in the morning versus some other diagnoses or other, um, you know, issues that people have in the healthcare field. Trauma is not planned. And I think that kind of governs a lot of what we do in MTQ, but also in this project. And, it's kind of limits us in a way in terms of how we have to approach some of these nuances with patients and stuff. So, question to answer today is what does a meaningful recovery after trauma really look like, and how should it be measured? But also, what is the path to really scaling these efforts that we're going to talk about in a trauma population? And how can trauma systems operationalize these data to really improve outcomes? That's kind of where we're all here. So I'm going to start with the perspective, and I love this picture. This is a perspective. I think it's a little bit tongue in cheek, but also I think kind of how we view trauma. And so this cute little 3-year-old, okay, it was an unknown mechanism, of course, because she's not the best historian at that age, but she had a laceration on her middle finger that she's kind of trying to show you. And so there was a treatment rendered, right? I'm kind of, again, tongue in cheek, local wound care and reassurance, and a Hello Kitty Band-Aid. And if we think about it kind of as in the trauma world, we solved the problem. We got her better. We got the patient better. She calmed down. It's going to heal. She's going to do well. Go on in life and do stuff. And so, but the thing is, we don't really know that, because after we put the Band-Aid on and maybe filled out some paperwork, we're kind of done. They get discharged and they go home. And so a lot of the questions we have in trauma kind of pertain to certain questions we don't know. Like, is this patient going to return to work, right? Get outside in the yard and take some stuff apart? Or is a budding dentist and pulling a tooth out from her brother being successful? Is she going to return back to work, to school, right, and get a completion certificate, or the activities of daily living? Those are things that people do normally at home, or work that kind of part of their lives, such as can she feed herself, or does she need help washing her hair, with her activity or with her injury? Is she return to activities like rock climbing, or playing sports? Or does she have another interaction with the healthcare system? Maybe not, because she's still hurting and still in some boot that's limiting her activities. Is she feeling okay? And I think this kind of sums it up. When you're in Meyer and you just have that great feeling of, hey, I'm loving life. She's got it going on here with the sunglasses, or maybe just having one of those days where you're just not having it, right? It's not working. And, is she getting back to normal sleep, conked out, or is she having problems with that? And those are questions that we really just don't know. We don't answer when the way we evaluate trauma. And so, again, getting to our perspective of kind of how this has been, this is a historic perspective that probably until the last I don't know, maybe 5, 10 years hasn't really changed. And so kind of we look at this with trauma, and this is more serious stuff, right? A car accident per se. And I think this has a lot to do. I grew up watching Emergency. It was a great television show, the early paramedics in LA County, Rampart. It was like in the 70s. I watched it. I'm not that old. It was on syndication when I saw it. But these were, I mean, these are the ballers, right? These guys went in and along with the crew at the hospital, took care of patients. It was very sensational. It was very, exciting. It's like they did this big stuff. And also, looking at the Committee on Trauma, which I'm just served on, the American College of Surgeons, that's a group that verifies trauma centers. When you say you have a level 1 trauma center, level 2 trauma center, this is a group that goes in and verifies that the trauma centers are appropriate. And again, looking at this immediate, this urgent, when the accident happened and saving these patients. And there it's me and my fellowship. I was at the Shock Trauma Center in Baltimore, Maryland. Again, one of the birthplaces of trauma, what we call the golden hour, and that's us on the helipad in our pink scrubs. And so taken all together, right, we're looking at trauma as this kind of acute event, right? And we're looking at these heroic life-saving measures, limb-saving measures. And that's kind of this lens that we look at, right? It's the acute hospital setting. But when I pose it, if I can use that term, that our perspective, I think, is a little bit off, and our perspective is a little kind of focused, and you'd probably say myopic. And if we look, the hospital encounter, right, the hospital time, granted, I mean, there's a lot of important stuff that goes on there, but that treatment phase is very small. And if we look at the time length of the patients and how they recover and of their journey, right, a lot more is maybe on rehab or rehabilitation and maybe future doctor visits, even more so on, getting back to play, getting back to work, and then getting back to like, are they feeling the same and are they back to where they want to be and like at home? And we really don't know the answers to this question. We don't know if these patients are really getting back to where they were before. And kind of a lot of it, and this is a rough thing, is we focus on mortality, right? Mortality is a big thing. It's easy, right? If someone dies, you can measure that. And this is, you can see that graph is hovering about 4%, going down a little less, right? And you can see this is the MTQIP average from 2013 to 2024. But prior to this, right, the reason why this probably focused is because in the 60s and 70s, when trauma centers came about and the verification came about and this organization, trauma care, as opposed to this haphazard way, the mortality was a lot higher. But we've really honed it down. And so, but this is that viewpoint is we view it as the big save, the trauma system. And so some of the limitations, right? But this is inherent because of the limitations of these trauma registries, which is basically big data sources of the trauma encounter of a patient when they go to a trauma center. And this is from both what's called the Trauma to Quality Improvement Program by the American College of Surgeons, as well as the Michigan one, the MTQIP, which is local to the state. So basically, when a patient is discharged, we really don't have any further data of anything of what happens to them, unless it's single center or an expert consortium. But on a grand scale, we don't have this data, and so we have these questions, right? We don't know what happens if they have more surgeries, if they have complications, how much money they cost, if they're going to rehab, and then if they're going back to work and they get back to work full time, or maybe they have a more sedentary job. We really just don't know these answers, and so that's kind of been some of the questions, and that's kind of why we're here today talking about how do we figure out what happens after the patients leave the hospital. And so, as I kind of alluded to, MTQIP is the Michigan Trauma Quality Improvement Program. It's all 35 level 1 and level 2 centers in the state of Michigan. It's voluntary, and it's sponsored by Blue Cross. And they basically take in data by data abstractors. It's validated based on this data standard. And the key part is they have regular meetings. So every so often, about 3 times a year, they get together and they talk about how do you improve outcomes? How do you improve process measures? What works at your center that might work at mine? And I think that's huge in terms of the collaborative. A lot of these collaboratives based at Michigan do this as well. And so kind of the earlier question we had was how could we maybe find some of these long-term outcomes, right? What goes on after the patients leave the hospital? And so what we did is we took their trauma registry, these patients in there, and then linked it up with their records in the Michigan Value Collaborative. And that's another CQI housed at Michigan that it's more than just having claims. They do a lot of other work. But what we use it for is to find out if these patients had downstream touch points with the hospital system in that. And so we did a couple studies, and one I'll just highlight is looking at VTE, which is a venous thromboembolism, so a blood clot. So if you had a blood clot after, it's a serious event. So you can especially go to your lungs and it can kill you. It's common in the trauma population. Well, we found that after they left the hospital. Again, this is a big black box because we don't track this and we didn't know this before to really quantify it. But about 73% of these happened within 3 months after discharge. And this was a huge rate. And it was actually about 4 or 5 times higher than the inpatient rate. And so that's something that we're looking at. How can we improve that? But how are these patients really doing, right? That's the question we want to ask, right? We can, maybe we can kind, I don't want to say quantitative data of these blood clots or infections we looked at, but how are the patients really doing, right? How do they feel subjectively? How are they doing objectively? And can we actually measure this? That's kind of the question, right? So we kind of broke it down. And again, I got feedback from very esteemed patient-reported outcome measure researcher, and he said you shouldn't use these terms, but I'm just for today, I'm going to use it. So kind of break it up into subjectively and objectively categories. So subjectively, we can kind of get information from the patients through what's called patient-reported outcome measures. And I'm no expert in this. I'm learning and reading and trying to get more understanding. But that again, that gets back to the team sport of nature of research that we have, a lot of people here that are very smart about this and learning from them. But what can you do? This is an active assessment. So you can inquire with the patients how they're doing, their pain, their mental health, their sleep habits. Are they sleeping better? Are they not? Their physical functioning. They might tell you I can barely go up a flight of stairs, or maybe I can run I can run a couple miles and I'm not winded. And there's ways to do that, and these are validated measures, and there's different ones. One's called the Euroqual, and I'll show you some later on, some of our early results that using this Euroqual measure. And then there's also what's called the Promise, which is this another one that we're going to use trying to use going forward, especially in our R01 and some of the upcoming research, and we'll talk about that. Objectively, however, we can do what's called actigraphy data. So it's like monitoring the patient's activity. And it's this passive monitoring, right, with certain technology. And that's, again, why we're here today. But that can see things like step counts or your heart rate, your pulse oximetry, again, your sleep cycles, which kind of neat. And I put et cetera because, and this is, I think, something I learned from the one of the last sessions, kind of not the last year, but the year before, through this group, is that the data is profound. And so what you can get more data than you know what to do with, and more variables than you know what to do with. And so you want to be careful about what you collect. And I think it was just amazing as to the amount of information that was available in the different categories that we didn't really know about until we started working with it. And so there's a couple of ways a lot of ways you can do it, right? And there's some examples like Apple Health, Google Health, and then also like Fitbit, when you're wearing it. And I'll show you more about that later, about how we're incorporating that into what we're doing. For those of you who aren't know, so this is the Promise 29. This is what we're using. There's different variations of this, but there's also different ones that are unique to certain categories of diagnosis, since this is version 2.0. This is just the first page. And so you can see on there that it breaks it down. There's of each domain, right? So for physical function, there's 4 different questions. And so, the top one, you can say, just an example, are you able to do chores such as vacuuming or yard work, right? And so maybe you have without any difficulty, all the way up to, unable to do so. And so that's a great way for patients to respond to really tell us how they're doing. And the Promise of the 29, the version 2, is broken down into multiple domains. And you can see them listed here, from physical function, anxiety, depression, fatigue, sleep disturbance, ability to participate in social roles and activities, kind of long, pain interference, and pain intensity. And then the last one, I think it's pain intensity measured on this on 10-point scale. And so how is it really used, right? And again, this is a rough description. Each domain has a raw score, and that's based on the item responses, and that's converted to a T-score. And the T-scores are standardized to the U.S. general population. And so just easy to understand, 50 is the population average, and then 10 points away from that is one standard deviation. So above and below is where the patients are from the population norm. And so then you have to say, well, what is better, right? So higher for physical function and social roles and activities, higher is better. But actually lower is better. So a lower score is better for anxiety, depression, fatigue, sleep disturbance, and pain interference. And then pain intensity is just scored on a 0 to 10 scale. So you kind of check, 0 to 10, where are you in pain intensity? And this is a little taking it to the next step, is for what we're thinking about doing is that there's all these domains, we want to kind of sum them up in a way and make it a little easier to work with. And so Ron Hayes developed these summary scores, physical health and mental health, and then That's kind of your weighting based on some code to take all those domains and convert them into just the physical health and mental health. And so that's what we're kind of going to be working with down the road when we get more data from our patients about their recovery. There are some issues though, right? So patient-reported outcomes do have some issues, right? There is a ceiling and floor effect, and that may limit the sensitivity, especially depending on what diagnoses you're looking at and what kind of patient population it might be tough to really see. You might not reflect real world performance with this in those certain patients. And really, meaningful change, how do you interpret that? It might be difficult. Like, yeah, they went up a standard deviation, above or below, but are they really better, right? They might not feel better. And this doesn't, the other thing is problems is they don't reliably report your actual physical activity. So that's kind of an issue, right? They might say that they're more active than they actually are. And so that leads us to actigraphy, right? So if they're not telling us, I mean, not intentionally how well they're doing, we could use actigraphy to give us a better sense of what they're actually doing in life. And so it's wearable devices, right, or smartphones that can capture this movement over time. You can use step count, your activity patterns, right? How much you're getting up and down, and you're active. Fitbit has categories like you're on elliptical, you're swimming, you're cycling outdoors, like all those different things. And that's just again, we're just cracking the surface on a lot of this right now with our group. And you can also look at sleep wake cycles too. I mean, it's very interesting now. We started beta testing. I'll show you a funny story in a sec about when you're wearing these and seeing what's affecting your sleep, especially as surgeon on call. It's kind of fun looking and see how well or poor my sleep is. When you get paged in the middle of the night and you wake up. And so with activity, right, this is continuous, it's passive data collection, right? And this is outside of the clinic or hospital. So when the patient's at their home setting, so we don't really see them, and it's kind of a way to really monitor them, I mean, not Big Brother wise, but and it really, we think, reflects what the patients are doing in actual life, in daily life. And then what we thought is this can complement the proms, right? One is good, the other is good, but maybe together, 1 and 1 + 3 is the MBA adage. So together, right, can we combine them together to like a composite measure? Is this going to provide a better understanding of these patients? This is something that we're toiling around with. And how do we even measure recovery, right? Because it's this term that we throw around, but what is recovery? What does it mean? And so this brings back to this, I think, kind of a funny story. When I was a resident, and one of our attendings asked, this is in pre-op, patient had like a femur fracture, tibia fracture, and said, well, what did you do before your accident? And this is a ChatGPT picture. The guy said, well, I kind of get up at the couch at the end of the day and watch TV. And, without missing a beat, with dry sense of humor, the he's like, well, I think we can get you back to that, what you were doing before. And I think, that kind of says a lot as to like, it kind of centers us as to trying to get the patients back to who they were individually and not a population mean. Because if you're trying to get a triathlete back to where they were and they hit the population mean when they leave the hospital after an injury, in theory, you're already succeeded based on data or based on how you're counting it. But in reality, they're really not there. And so we came up with this idea about, and again, it's not ours, but just how we view and picture recovery for a trauma patient, right? And so we figure that, right, like getting back to the couch potato or maybe a triathlete, right? They have a certain baseline. This is where they function. And they're going along at a certain peak until they hit the injury, right? Again, no one counts on this. And when they have that injury, there's a sudden precipitous drop in their health, right? It drops down, and this is time zero. But over time, and this is the baseline, we feel that maybe they can recover. Maybe they can get back to, and don't worry about the RCI, but that's just kind of a flux factor, maybe a statistically, way of saying that they're within a mechanism, or sorry, a way of their baseline, right? They're within a certain unit of their previous baseline, and we'd say they're recovered. And so, however, there are also patients, right, that have an injury and maybe they have like a partial recovery. They don't get back to their baseline. And there could be a variety of reasons why that doesn't happen. Like we just don't know. And there's others that might have like minimal or no recovery. Maybe they had a horrific injury. Maybe they start out and they're just not great, have a lot of physiologic reserve to recover. And so we just don't, these are the patients, this is what we're trying to figure out. And so kind of as an example, right, that's a femur, okay, an x-ray of a femur, the left femur. And this is a 22-year-old female. She was a grad student, and she also works at like the ice cream shop. And she was just tumbling around and she broke her femur, which is kind of a weird mechanism, but everything's sorted out and it was fine. But she did it. So it was, we do what's called an intramedullary nail. So we put the nail down, the rod down, stabilizer. You can see that there's, the bones lined up really well. That little ditzel piece, that's fine. And that's like after surgery. Here's a few months more now, that bump that's called callus, and that's the bone healing around the fracture site, which is good. And then about 6 months time, I saw her again, and it's like, whoa, she is pretty much healed, right? She's doing well, wants to go back, wants no restrictions, wants to be back at work, back at school. And it's like, she's like, do I need to come back and see you again? And this person probably fully recovered if we look at this. And again, this is kind of a quantitative nature, right? This is looking at x-rays and this versus, wasn't patient reported outcomes or actigraphy, but, she felt that she was done versus another gentleman, again, about a 24-year-old guy, is in a motor vehicle collision. He had a couple other injuries, but this is one of them. So it's, again, a femur fracture is broken. He's a laborer. He doesn't really have great insurance, but he's compliant. He's a nice guy, and I just wish he had better results. So I put that rod down there, and maybe I distract him a little bit. I was trying to get his what's called length and rotation, so the femur was put on the right way, so his foot was, pointing the right way when we're all said and done. And so, we did this, and then a couple of months later, you can still see maybe a little resorption at the fracture site. It's still that gap. And then I watched that for a little bit and actually put some bone graft from his higher up in his pelvis, and I put that down there to help because I was like, it's not healing, and he still has a little discomfort, and he's not really doing. I mean, he's not 100%. He's doing okay. And then down the road, it's like a little bit more callous, and but it's just he's still kind of tweening along, and it's kind of one of those things where it's like I just wish it was better. I wish he was healed completely because if he was looking at, he's probably not completely recovered, and so that's maybe just a way to kind of frame that as to him going forward and of what these phenotypes are. All right, so now what? So can we even pull this off, right? I mean, it's like, has anyone ever done this before? Maybe my PubMed search wasn't that great. This kind of seems technologically advanced. I don't know if we can really do this. And let's try not to reinvent the wheel when we're doing this. Well, we found out there's an app for that. And so I want to say thank you to Nicole and to Victoria from Metric and also Department of Anesthesia for really helping us down and guiding us. You guys are great. I don't know if you're on, but just you kind of a little the blind leading the blind on our end, and you really helped point us in the right direction because we got hooked up with My Data Helps, and you guys probably know more about My Data Helps than we do. It's a care evolution product, a HIPAA compliant platform that we're using. We're just again scratching the surface of what it's capable of. But what we're doing with that is we're using it as kind of the base with the patients that's put on their smartphones. So we have these injured patients with the My Data Helps app, and it helps us. We can port out promise surveys to them at regular intervals, and also we give them patients a Fitbit who are injured, and it links up with the My Data Helps and helps pull that information and track it so we can see their actually activity together. And that's kind of basically the crux of what we're doing right now with patients, kind of going forward in our improving trauma recovery study. But the quiz, right, is like, how do you measure the baseline? And I think this is something that we promoted because, and I was talking to my son last night, he's 15, and he got it because, again, it gets back to the kind of couch potato versus the triathlete, right? If you're measuring people back to the population average, right, the couch potato is never going to get to that population mean. And the triathletes already reached the mean probably before they leave the hospital after their traumatic event. So it's really not, I don't think, worthwhile if you're trying to compare people instead of comparing them to themselves. So what we've done, we proposed is, do you have a smartphone? And so, yes, there is a selection bias because we're only using right now people with smartphones, and they also have to have pre-activity or pre-injury activity data. So data that their step counts. Again, it's not sleep cycles because they're not wearing anything. We're not counting on that, but just their step counts right now to see what their kind of baseline was. And again, it's very cursory, but this is what we're starting with. All right, so let's beta test. So again, another X-ray. Here you go. This is a intra-op image. This is a patient. This is a different patient. This is not someone in the study. This is one of my patients has been treated. You can see the plates are broken, screws are broken because he has what's called a non-union. Multiple years of dealing with this. He smokes. He's not got great medical comorbidities, and so it's been a struggle. So we're taking out the hardware, and this is not a stressful situation. Trust me. I had my chief resident doing this. I wasn't scrubbed. I was watching. I was just more like, why is it taking so long? Let's go. But I was feeling my heart was a little racing. We were beta testing, and I was wearing the Fitbit, a little chest pain. And I'm looking down, I'm like, whoa, I'm tacking away. And this is me. So yeah, it's getting a little high, and I don't know why this is happening, but at least I could monitor it. And long story short, I just had a little tachycardia. That's me in the hospital getting worked up. I'm fine, but I thought it was hilarious that I could use this Fitbit so that I could figure out what's going on with myself and know that my heart rate was racing. So, with that, we've submitted for, and we just received a score of competitive and not discussed. So, for those that are familiar with NIH and the recent forays there, we don't know what that really means, but they're kind of getting through the backlog after the shutdown. And this is basically what we're doing. It's similar to what I've described, where we give people a Fitbit, we have them download My Data Helps onto their iPhone, and we're sending out patient-reported outcomes at a set time of so many weeks, 2, 6, 12, 24, and 52 weeks, along with tracking their continuous data, their actigraphy data and step counts and whatnot. We're also beginning to incorporate people that had like smartwatches or Garmin's, or previous Fitbits. We're kind of not trying to exclude people who are like, I really like my smartphone or my Apple Watch. Can I still wear that? And so we're learning. We're trying to figure that out and let them, keep using that. So that's one of the aims. Then the next part is we're trying to figure out those that don't recover. And so patients, we're trying to figure out the phenotypes of patients with a latent class analysis, because if you can imagine the trauma population is pretty heterogeneous, right? It's not all the same people. And so different people might recover in different ways. And it also includes different different injury patterns and injury burdens. So we're still trying to figure that out. And so we want to figure out, and then with some interviews, of these groups or types of people, why don't they recover, right? Is it something that's going on? Like maybe it's food insecurity, maybe it's pain, maybe it's some psychological issues, or maybe it was just a horrific injury that's hard to recover from. And then lastly, we want to do a Delphi panel that will basically identify kind of what's the best what are the best interventions that we should look at to study with some actual intervention you know um, analysis with future research. And so that's kind of what we're setting up with the R01. We'll see him talk to the program officer hopefully soon, and we'll figure out if this is dead in the water, if we can keep going with this and resubmit. So here we are now. We have 29 patients that have responses. 12 of them have 24-week surveys, right? So this is pretty impressive. We are paying people on a graduated amount. So every time they get a little more, every time they complete a survey. And honestly, as someone that's done trauma for a lot of years, I'm surprised it's going this well in a good way. Not trying to be a doubting Thomas, but trauma patients are a different group, and it's hard and I'm surprised it's going this well. I'm happy, and we're gonna run with it. It's going to be a multi-center study when it all said and done. We're going to incorporate with Bronson Health Center in Kalamazoo and U of M Sparrow and Lansing to kind of get more patients and more diverse patients in terms of background and injury patterns. So this is kind of switching gears just a little bit. This is kind of some work that we did with patient-reported outcome measures in the past, recently using the EuroQual 5D, not the PROMIS. And so it's a little different, but we have some kind of interesting results. Again, early we've been writing this up and putting it out there. But this is a different way. This wasn't with meeting the patients in the hospital. This is after they had left and using the registry to identify patients and then contact them down the road, either through email or text or telephone. And then that was using, I think, initially Qualtrics and then now REDCap to get the patients to answer the questions. And so EuroQual 5D, 5L, so you can see there's 5 domains: mobility, self-care, usual activities, pain and discomfort, and then anxiety and depression. You can see how it's oriented with the answer choices. And so this data, we actually had a lot of responses. So over 1,100 patients, over 1,600 surveys are completed. And this is, at the time, 22 trauma centers. And now, based on agreements, we have all 35 centers are in the mix to do this. And so very simply, right, this is just, so the EQ index is kind of a summation and of the domains, and comes up with a number based on some code to show kind of an overall score, this index score. And you can see as the increase in number of surveys, so based from your first survey to your 5th survey, roughly, that there's an overall, and this is also has to do with time as well. So the 5th survey is obviously after, or the 4th survey is actually after the first. You can see that there's a gradual increase, and higher score is better. So there's a gradual increase from just over 0.6 to just over 0.8. And so it's the people are overall, again, this is not specific types, it's overall people. So it's a whole group are getting better, right? So that's a good thing. And then again, if this is just another way to look at it, based on the time frame. So between, again, the survey blocks were huge. It wasn't a very tight window when we were answering the surveys. But you can see overall, as time goes, the patients are, as a whole, getting better. So that's good. And then we broke it down into groups, or sorry, into domains, and asked a question. We looked at so for say mobility, right? And we clustered or grouped when people had no problems or slight problems compared to moderate, severe, and extreme. That over time there was significant improvement. Okay, people got more mobile. They were better over time from their first to their third survey. We did the same thing with self-care. Over time, people had less or fewer problems or no problems in their ability for self-care over time from their first to third month. So again, people are kind of improving, right? You would hope that. Usual activity, right? Doing their usual things that they want to do when they had no, people said they had no problems. Again, that increased and was different than when you're having some problems or extreme problems. So again, people are kind of getting back to doing stuff and feeling better, or sorry, but when you looked at pain, there was no change in pain. People had kind of the people that had no pain at the beginning kind of had the same pain at the end, similar with extreme, similar with the different levels. So that wasn't something that was improving on. And also with anxiety and depression, again, what you kind of started with, it didn't really get a lot better over time. So those that had moderate problems, severe and extreme, had about same number of people were having the same issues down the road. So that's kind of something else that's kind of on our radar as to what maybe we need to hone in on to help these patients get better. We asked questions about caregiver support, and there's a decent amount of patients that, they worked less or they had to quit their job. Their caregiver did to take care of their patients, or they had to hire help or, change their residence. So that's, again, another issue when you're incorporating or bringing other people into care for you if you have a traumatic event. So the question is, right, how do you scale this? Because right now we're just at the University of Michigan, it's a trauma center, or maybe going to two other places. But there's 35 centers now, 34 in the state that are part of MTQIP. You see all those dots there, right? There's about 30 to 35,000 patients per year that are admitted and put in the MTQIP registry. That's a lot. And we're engaging these patients for 1 year's time. So it's a lot of work to keep track and keep manage them. And there's also the cost of wearables, right? And the staff to monitor this. But it maybe, I think this is something to think about where, in a bigger picture, that there's maybe insurance redesign, right? Because again, getting back to the kind of myopic view of trauma, it's in everyone, especially the payer's interest, to get these patients back, I don't say back to work, but that's a lot of what it is, and getting back to their previous level. So, if $100 Fitbit and some money for data management is all that it takes, it's a pretty good return on investment, I think. And it's probably a matter of selling it when we get more data to show. So, remember, trauma is not elective. And that was the thing I kind of touched on at the beginning. Unlike some of the other collaboratives where, say, and again, this is nothing against the other collaboratives, but if you're having a joint replacement, you go to Marquis, and Marquis is the joint registry or joint collaborative for the state, probably the best in the world, honestly, and I'm biased. I think Brian Hallstrom and Richard Hughes have done a great job, but there have, relationships developed with their patients that they put in the registry prior to the surgery, right? It's a buildup, as opposed to like with trauma, where it's like we're meeting these people, with no pre-existing relationship. We're meeting these people around a terrible event, right? So they just had something horrific happen to them, and we're like, "Hey, would you want to be in this? Can we monitor you after you leave the hospital and have you answer all these questions and be a part of this?" And so it's kind of a tough play. So they're also dealing with, they're going to rehab or they're trying to get better on their own. They're like, I really could care less about running a Fitbit or answering your questions. And, maybe they're going somewhere else, like they're going to a nursing facility that's not the greatest and they're having to deal with those problems. They're in a lot of pain probably, and they're, they don't want to deal with that, or it's a severe life stressor. And so I think there's a lot of these issues that we kind of have to deal with and tackle as we go forward with trying to enroll more trauma patients, get more people involved in this. So I think this is kind of, I like this. It's kind of, so in that regard, how can we like approach more people easily without having, all this direct constant patient access? So here's a little video we created. It's very short, but.
Hi there, we're sorry you were involved in an accident, and we want to learn more about what you are going through. We are part of the Michigan Trauma Quality Improvement Program, a surgical quality improvement initiative dedicated to improving the care delivered to trauma patients in Michigan. Our team is led by Doctors Mark Hemela and Bryant Oliphant, attending surgeons at Michigan Medicine and the Detroit Medical Center. While the University of Michigan serves as our coordinating center, our group collaborates with 35 trauma centers across Michigan, even including the Upper Peninsula. We would like to invite you to participate in the Michigan Trauma Quality Improvement Program Patient Reported Outcomes Study, a study investigating patient recovery using wearable health devices and surveys through an app called My Data Helps, available on Apple and Android devices. We still want you to focus on getting back on your feet and being discharged as soon as and as safely as possible. Once you leave the hospital, we would start measuring your recovery through your wearable health device and periodic surveys, assessing factors including your physical function, emotional well-being, and pain levels, so that we can evaluate your return to your pre-injury levels of functioning, without us actually being there alongside you. Our goal is to use your experience to identify any barriers to recovery and potential interventions so that we can help patients like you in the future. As a study participant, you would be responsible for completing all surveys on time, wearing the health device consistently each day, and notifying us if you experience any adverse effects or issues. You also would receive financial compensation for every survey you complete and get to keep the wearable health device when you are done. And don't worry, your information will be kept private and secure. All data will be de-identified, and your personal information will be completely confidential. Thank you so much for considering to be part of our study. If you are interested, please contact us to get started. We wish you all the best in your recovery.
So yeah, so that was I thought of that when I was sitting in the waiting room with my tachycardia and saw some of the cool Michigan, at least the uh, animation and whatnot. I was like, well, why can't we do that too? So kind of hopefully save some time and it allows us to, kind of be a force multiplier to reach more people. So the other thing we want to do with this though is down the road is probably maybe what's called the just-in-time intervention. So that's maybe where patients are compared against people like themselves, right? Is to see how are they doing, right? And this shouldn't be punitive or demeaning, but maybe patients want to know how they're doing, um, to see. So again, here's ChatGPT and some great, uh, idea or images based on my ideas. So right, so you have this trainer, and then you have this tracker, right, in your iPad or your phone, and you're getting better, but it's like, hey, I'm ahead and I'm about where I should be, or maybe I'm not, or maybe I'm ahead of the game, and so that could be one way that we can feedback this information to patients. The other way is also that we can utilize what the MTQIP collaborative, right? And just like the other collaboratives that, we can hopefully, we can, a couple ways we can affect patients at the time of their treatment, but also maybe downstream. And right. And this is just adds to our data. And it's a cycle, right? Where you get data, we analyze it, and then we share it with the collaborative. This becomes information, and then this results hopefully in change. And that's the big thing. So hopefully that we can utilize the infrastructure that we have going on to take this and kind of add another, avenue to what we have going on already. Because the goal of collaborative, right, is to get better, and it's also to help each other. And so instead of just you standing on the top of the thing, it's, can you help people get better? So I'm going to end with, this worked out time-wise great. So that's the Apple One. I put that up there because I think it's kind of like we're really at the beginning of this. It's kind of exciting. We're still trying to figure it out, but I think that, I think looking at my uh, MacBook Pro here that's pretty awesome, and nothing, dwarfs whatever that is. But I mean, to go from that to what I'm, working on, I think there's a tremendous potential, and I think the future is bright. I think it's really exciting to be in this space, and it's exciting to be at Michigan with all these, a lot of people, especially that are helping us out, and all the groups available. And so, and then ending with this is that driving to this weekend to a volleyball tournament with my daughter, and like we just eaten and got back in the car, and it was like right around the time where Artemis 2 is coming through the atmosphere, and so we got on YouTube. I was driving safely, of course, hooked up to the car. And I'll be honest, I was glancing out at the screen occasionally, trying to see, when the drogue chutes are coming out and the big parachutes and stuff. And it was just absolutely amazing. I mean, to the minute landing in the ocean of what they predicted. And I was like, if they can do that, I mean, why can't we monitor our patients and make the recovery better? And so I just, it was inspiring, it was really cool. But I was thinking, it was like there's nothing really we can't do. We put four people around the moon and brought them back to the minute, and I just thought that was cool. So.